The gastrointestinal system presents unique challenges in neonatal care, from life-threatening emergencies requiring immediate intervention to complex congenital anomalies demanding specialized management. Mastering GI assessment and care is essential for every neonatal nurse practitioner. Today, we'll explore the critical concepts you need to recognize, assess, and manage these conditions with confidence. By the end of this session, you'll have a comprehensive understanding of neonatal GI disorders, from embryology through management. These objectives align directly with certification exam content, focusing on the high-yield concepts that appear most frequently. Each section builds on the previous, creating a systematic approach to GI assessment and intervention. Understanding embryology is fundamental to recognizing GI anomalies. The primordial gut forms during week 4 and divides into 3 distinct sections, each with its own blood supply: celiac artery for foregut, superior mesenteric for midgut, and inferior mesenteric for hindgut. The critical period of physiologic herniation and rotation sets the stage for many of the anomalies we encounter. When this process goes awry, we see malrotation, atresias, and abdominal wall defects. A systematic abdominal examination is your first line of defense in identifying GI pathology. Always inspect before touching. The abdomen should be soft, rounded, and symmetric. Auscultate before palpation to avoid altering bowel sounds. Normal neonatal bowel sounds are high-pitched and occur every 10 to 30 seconds. The liver edge normally extends 1 to 2 centimeters below the right costal margin. Document your findings precisely. This baseline assessment becomes critical when monitoring for changes. Understanding neonatal GI milestones provides the foundation for recognizing pathology. These benchmarks distinguish normal function from conditions requiring intervention. Meconium passage timing is clinically critical. 95% of healthy term infants pass meconium within 24 hours, and 99.8% within 48 hours. This timeline is essential for certification exams. Failure to pass meconium by 48 hours indicates either Hirschsprung disease or mechanical obstruction and demands immediate investigation. The stool transition follows a predictable pattern. Meconium appears in the first 1 to 2 days, followed by transitional stools during days 3 to 4, then mature milk stools by day 5 to 7. This progression reflects normal gut colonization and feeding establishment. Stooling frequency varies significantly by feeding type. Breastfed infants produce 5 to 12 stools daily due to the laxative effect of human milk and more complete digestion. Formula-fed infants typically have 3 to 6 stools daily. Understanding this difference prevents unnecessary concern about frequent stools in breastfed babies. Gastric residual assessment guides feeding tolerance. Residuals less than 30% of the previous feeding volume are considered normal. Residuals exceeding this threshold suggest feeding intolerance, delayed gastric emptying, or obstruction. Abdominal circumference normally remains smaller than chest circumference after 32 weeks gestation. This relationship helps identify abnormal abdominal distension. These milestones aren't just developmental markers, they're diagnostic tools. Deviations from expected patterns often represent the first signs of serious GI pathology, making accurate knowledge essential for early recognition and intervention. Here's what every neonatal nurse needs to recognize about red flag findings. These require immediate intervention. Bilious emesis is the critical finding. Green vomit in a neonate indicates obstruction distal to the ampulla of Vater, and you must assume malrotation with volvulus, until proven otherwise. This represents a surgical emergency where bowel viability depends on rapid recognition and intervention. Absent bowel sounds require careful assessment. Listen for 3 full minutes before documenting absent sounds. This finding suggests either ileus or perforation, both requiring urgent evaluation. Abdominal circumference increases greater than 10% in 24 hours, signal obstruction or developing MEC. When you observe visible bowel loops through the abdominal wall, particularly with erythema, this indicates significant bowel distension and inflammation. Bluish discoloration of the abdominal wall suggests intraperitoneal bleeding from perforation or peritonitis. This finding demands immediate surgical consultation. Failure to pass meconium within 48 hours indicates either Hirschsprung disease or mechanical obstruction. This milestone is clinically significant and requires investigation. Your immediate response to these findings should be systematic. Establish NPO status, decompress the stomach with continuous suction, obtain appropriate imaging, and notify surgical services. These aren't subtle clinical signs. They represent urgent pathology requiring immediate action. The key concept for certification exams is recognizing that these findings indicate life-threatening conditions. Early recognition and prompt intervention directly impact patient outcomes and prevent progression to more serious complications. When you encounter bilious emesis, you're dealing with a true emergency that requires immediate, systematic intervention. Understanding the rationale behind each step is essential for effective management. First, establish NPO status immediately. This isn't simply about preventing aspiration. When obstruction is present, continued feeding worsens distension and increases perforation risk. Every minute matters when bowel viability is threatened. Gastric decompression with a replogal tube on low continuous suction serves dual purposes. It relieves pressure building proximal to the obstruction and prevents further vomiting. This decompression can improve blood flow to compromised bowel while reducing aspiration pneumonia risk. Fluid resuscitation must be aggressive. D10W with electrolytes at 1.5 to 2 times maintenance. These infants lose fluid through multiple mechanisms. Vomiting depletes gastric contents, third spacing moves fluid into bowel and peritoneum, and poor intake creates baseline dehydration. The dextrose maintains glucose homeostasis, while increased rates replace ongoing losses. Initiate broad-spectrum antibiotics immediately. Ampicillin plus gentamicin provides coverage against likely organisms. When bowel becomes compromised, bacterial translocation occurs rapidly. You're preventing infection, not treating established disease. Contact surgery before obtaining imaging. This sequence is crucial. If imaging confirms malrotation, surgical intervention must occur within hours. Early surgical awareness prevents critical delays that could result in bowel loss. Laboratory workup targets surgical decision-making. CBC reveals infection or ischemia. Electrolytes guide fluid management, and blood cultures establish baseline before antibiotic therapy. Avoid plain radiographs as initial imaging. While expedient, they provide false reassurance. The upper GI series remains definitive, demonstrating duodenojejunal junction position and revealing the characteristic corkscrew appearance of malrotation. This systematic approach addresses both immediate stabilization and diagnostic confirmation while optimizing outcomes through timely intervention. Understanding malrotation pathophysiology requires grasping both the normal developmental process and what goes wrong when it fails. The embryology centers on a critical 270-degree counterclockwise rotation that occurs between weeks 6 to 12 of gestation. During normal development, the midgut herniates out of the abdominal cavity, rotates precisely, then returns to fix properly to the retroperitoneum. When this rotation is incomplete or abnormal, malrotation results. The anatomical defects create a perfect storm for volvulus. The narrow mesenteric base represents the most dangerous consequence. Instead of the normal wide attachment from the ligament of Treitz to the right lower quadrant, the entire midgut hangs from a narrow pedicle. This creates the mechanical setup for twisting. The absence of normal retroperitoneal fixation means the bowel lacks its usual anchoring points. In normal anatomy, the duodenum curves around the pancreas and fixes retroperitoneally, while the colon attaches along the posterior body wall. Without these attachments, the intestine remains mobile and unstable. The abnormal position of the ligament of Treitz is diagnostically significant. Normally, this junction sits to the left of the spine at the level of the duodenal bulb. In malrotation, it fails to cross midline or sits abnormally low, indicating incomplete rotation. The cecum's failure to fix in the right lower quadrant creates additional problems. Instead of normal positioning, it may sit high with fibrous bands crossing the duodenum, creating additional points of obstruction. When volvulus occurs, the twisting motion occludes the superior mesenteric artery, the single vessel supplying the entire midgut. This vascular compromise progresses rapidly from venous congestion to arterial occlusion. The time sensitivity cannot be overstated. Intestinal ischemia begins within 4 to 6 hours of onset, and irreversible necrosis follows shortly after. This narrow window explains why any bilious emesis demands immediate evaluation. The entire midgut can be lost if diagnosis and intervention are delayed. Understanding the clinical presentation of malrotation is essential because early recognition directly impacts bowel viability and outcomes. The age distribution reveals important patterns. 60% of cases present within the first month of life, and 80% by 1 year. This early presentation reflects the severity of anatomical abnormalities. The most unstable configurations tend to develop volvulus sooner. However, malrotation can present at any age, making it a diagnostic consideration throughout childhood. The classic presentation is unmistakable when it occurs. Sudden onset of bilious emesis in a previously healthy, thriving infant. This infant was feeding normally, stooling appropriately, and showing no signs of illness until the acute onset of green vomiting. This abrupt change in a well-appearing baby should immediately trigger concern for malrotation with volvulus. The symptom progression follows a predictable timeline that correlates with the degree of vascular compromise. In the early phase, within the first 4 hours, bilious emesis dominates the presentation with only mild abdominal distension. The abdomen may appear deceptively benign during this crucial window. There's often minimal tenderness or guarding because ischemia hasn't yet progressed to significant bowel necrosis. As we move into the intermediate phase from 4 to 12 hours, ischemia progresses and clinical signs worsen. Irritability increases as visceral pain develops. Abdominal tenderness becomes more apparent as the bowel wall becomes edematous and inflamed. The infant may demonstrate signs of discomfort with handling or positioning. The late phase, beyond 12 hours, represents advanced ischemia with life-threatening complications. Hematochezia indicates mucosal breakdown and bleeding. Hemodynamic instability reflects fluid losses, inflammatory mediator release, and potential sepsis. Peritonitis develops as the bowel wall integrity fails. Atypical presentations create diagnostic challenges. Some infants experience intermittent partial volvulus, where the twisting occurs but spontaneously reduces. These cases present with chronic symptoms, recurrent episodes of irritability, feeding intolerance, or intermittent vomiting. While less dramatic, these presentations carry the same risk of catastrophic complete volvulus. The deceptively minimal physical findings early in the course represent a critical teaching point. Don't rely on abdominal examination to rule out malrotation. The absence of distension or tenderness doesn't exclude this diagnosis when bilious emesis is present. Diagnostic approach for malrotation requires understanding the strengths and limitations of each imaging modality to ensure accurate and timely diagnosis. The upper GI series stands as the gold standard with impressive diagnostic accuracy, 93% sensitivity, and 97% specificity. This contrast study directly visualizes the anatomical relationships that determine malrotation. The key finding is the abnormal position of the duodeno-geunal junction, which should normally cross to the left of midline at the L1-L2 level. In malrotation, this junction fails to cross midline or sits abnormally low, indicating incomplete rotation. When volvulus is present, the upper GI demonstrates characteristic findings. The corkscrew appearance occurs as contrast spirals through the twisted duodenum, creating a distinctive pattern that confirms both malrotation and active volvulus. The bird's beak appearance represents the tapered narrowing at the point of obstruction where the bowel twists. The absence of the normal duodenal C-loop provides additional diagnostic information. In normal anatomy, the duodenum curves around the pancreas, creating a characteristic C-shaped configuration. Malrotation disrupts this normal course, and the loss of this landmark supports the diagnosis. Abdominal ultrasound offers a potential alternative, particularly when upper GI series isn't immediately available. The whirlpool sign represents twisted mesenteric vessels around the superior mesenteric artery. However, this finding is highly operator-dependent, requiring significant expertise to identify reliably. The sensitivity varies considerably based on the sonographer's experience and the infant's body habitus. Plain radiographs have severely limited utility in malrotation diagnosis. While they may occasionally show suggestive findings like the double bubble sign of duodenal obstruction or a gasless abdomen, these findings are neither sensitive nor specific for malrotation. More concerning, plain radiographs can appear completely normal even in the presence of malrotation with volvulus. The critical teaching point about plain radiographs cannot be overstated. A normal abdominal X-ray does not rule out malrotation. This misconception has led to delayed diagnoses with catastrophic outcomes. The normal gas pattern can persist even when significant volvulus is present, creating false reassurance that delays definitive imaging. When malrotation is suspected based on clinical presentation, proceed directly to upper GI series rather than relying on plain foams. Time is bowel, and the minutes spent obtaining non-diagnostic imaging can mean the difference between bowel salvage and massive resection. The LADS procedure represents the definitive surgical management for malrotation, addressing each anatomical abnormality systematically to prevent future complications. Counterclockwise detorsion of volvulus is the first critical step. The surgeon untwists the volvulus in the same direction as normal rotation should have occurred. This maneuver must be performed carefully to avoid further compromising already ischemic bowel. The counterclockwise direction follows the natural embryological rotation pattern. Division of LADS bands eliminates the abnormal peritoneal attachments that tether the cecum and create duodenal obstruction. These fibrous bands cross the duodenum and represent the colon's attempt to achieve retroperitoneal fixation. Complete division is essential. Any remaining bands can cause future obstruction even without volvulus. Placement of small bowel on the right and large bowel on the left creates what's called non-rotational anatomy. This positioning may seem counterintuitive, but experience has shown that attempting to create normal anatomy doesn't work. The non-rotational configuration is stable and functional, reducing the risk of future volvulus by eliminating the narrow mesenteric base. Widening the mesenteric base addresses the fundamental problem in malrotation. By spreading the bowel across a broader attachment, the surgeon reduces the mechanical stress that predisposes to twisting. This broader base provides better vascular stability and reduces volvulus risk. Appendectomy is performed because the appendix ends up in an abnormal position after the LADS procedure. Its unpredictable location would complicate future diagnosis of appendicitis, making this prophylactic removal standard practice during the procedure. The timing cannot be emphasized enough. This is emergent surgery upon diagnosis. Unlike many pediatric conditions where optimization precedes surgery, malrotation with volvulus represents one of the few scenarios where operating takes precedence over complete resuscitation. Every hour of delay increases the risk of bowel loss. Viability assessment presents one of the most challenging aspects of the procedure. When bowel viability appears questionable, the surgeon must decide between immediate resection and a second-look approach. The planned second-look procedure at 24 to 48 hours allows potentially viable bowel to declare itself after adequate resuscitation and reperfusion, potentially saving bowel length that might otherwise be unnecessarily sacrificed. Post-operative management after the LADS procedure requires understanding that the manipulated bowel needs time to recover normal function while maintaining adequate nutrition and monitoring for complications. Nasogastric decompression continues until bowel function returns, typically 3 to 5 days, but potentially longer, based on operative complexity. The bowel has been extensively manipulated during surgery, and normal peristalsis takes time to resume. Don't rush this process. Premature feeding attempts can lead to distension, vomiting, and potential complications. Monitor for the return of bowel sounds, passage of gas, and decreasing gastric output as indicators of recovering function. Parenteral nutrition via central access becomes essential during this recovery period. These infants often require several days to weeks of TPN while bowel function normalizes. Central access is preferred over peripheral because the anticipated duration exceeds what peripheral veins can safely support. Early placement prevents delays in providing adequate calories and protein for healing. Antibiotic duration depends on operative findings. When no perforation or gross contamination occurred, 24 to 48 hours of prophylactic antibiotics suffice. However, if perforation was present, or there was significant bowel necrosis requiring resection, extend antibiotics to 7 to 10 days to treat potential peritoneal contamination and prevent intra-abdominal abscess formation. Serial abdominal examinations monitor for complications like bleeding, infection, or early obstruction. Watch for increasing distension, tenderness, or signs of peritonitis. These examinations also assess the return of normal bowel function. Decreased distension and softer abdomen indicate recovering peristalsis. The feeding advancement protocol follows a gradual progression once bowel function returns. Start with clear liquids to test tolerance, advance to half-strength formula, then progress to full-strength feedings. This stepwise approach prevents overwhelming the recovering bowel with complex nutrients before it's ready. The manipulated bowel may have temporary dysmotility, making slow advancement crucial. Long-term follow-up addresses the 15 to 20% risk of adhesive bowel obstruction. Educate parents about warning signs, including bilious vomiting, abdominal distension, and changes in stooling patterns. These symptoms may develop weeks to years after surgery, as adhesions form and mature. Early recognition prevents progression to complete obstruction and potential bowel compromise. Understanding NEC pathophysiology requires recognizing that this devastating disease doesn't result from a single cause, but rather from a perfect storm of multiple factors converging at the worst possible time in a vulnerable infant's development. Let's start with the foundation: intestinal immaturity and impaired barrier function. Think of the premature infant's intestinal tract as a fortress with incomplete walls. In a full-term infant, the intestinal barrier is like a well-constructed castle wall with tight junctions between cells, adequate mucus production, and mature immune defenses. The premature infant's intestine, however, resembles a fortress still under construction. The walls have gaps, the defenses are incomplete, and hostile invaders can easily breach the perimeter. This immature barrier cannot effectively prevent bacterial translocation, which means harmful bacteria that should remain confined to the intestinal lumen can cross through the intestinal wall into the bloodstream and surrounding tissues. When bacteria breach this compromised barrier, they trigger an inflammatory cascade that the immature immune system cannot properly regulate. The second critical component involves abnormal microbial colonization. In healthy development, beneficial bacteria gradually colonize the intestine, creating a protective environment. However, the NICU environment, with its necessary but disruptive interventions like antibiotics and invasive procedures, disrupts this natural process. Instead of beneficial bacteria establishing dominance, potentially harmful organisms can flourish unchecked. Formula feeding versus human milk protection represents one of the most significant modifiable risk factors. Human milk provides remarkable protection through multiple mechanisms. It contains immunoglobulins that coat the intestinal surface, growth factors that promote barrier maturation, and oligosaccharides that selectively feed beneficial bacteria. Formula feeding increases NEC risk 6 to 10-fold because it lacks these protective elements and can actually promote the growth of pathogenic bacteria. The pathological sequence follows a predictable but devastating progression from mucosal injury to bacterial invasion to inflammation to necrosis. Initial mucosal injury can result from various insults: ischemia, feeding intolerance, or medication effects. Once the mucosal barrier is compromised, bacteria invade the intestinal wall. The immature immune system responds with an exaggerated inflammatory response, releasing cytokines and inflammatory mediators that cause further tissue damage. This inflammation progresses to necrosis as blood flow becomes compromised and tissue death occurs. Understanding risk factor significance helps us identify the most vulnerable infants. Prematurity, especially before 28 weeks gestation, represents the highest risk because it encompasses all the vulnerability factors. Immature barrier function, altered immune response, and prolon. Understanding NEC epidemiology reveals predictable patterns that guide our clinical vigilance and help identify the most vulnerable infants. The incidence statistics demonstrate the profound impact of prematurity. Very low birth weight infants under 1,500 grams face a 2 to 8% NEC risk, but extremely low birth weight infants under 1,000 grams see rates jump to 8%. The most vulnerable group, those born at 22 to 24 weeks, experience NEC rates of 10 to 15%, compared to less than 1% in term infants. Each week of gestation provides crucial intestinal maturation. The timing patterns reveal important pathophysiology insights. Paradoxically, the most premature infants develop NEC latest, around 23 days for those under 26 weeks, versus 11 days for 30 to 32-week infants, and just 3 to 5 days for term babies. This isn't protection. It's the time required for the perfect storm to develop. Extremely premature infants need weeks for bacterial colonization, feeding exposure, and system overwhelm to occur. The terminal ileum and proximal colon bear the brunt of disease because they represent watershed vascular zones. During stress, hypoxia, hypotension, inflammation, these areas receive the least perfusion, making them most vulnerable to ischemic injury. Mortality statistics underscore NEC severity, 15 to 30% overall mortality climbing to 50% when surgery becomes necessary. Surgical cases represent advanced disease with extensive necrosis and systemic compromise. These patterns guide our approach. We maintain highest vigilance in extremely premature infants around 3 to 4 weeks of age when their risk peaks. Understanding these epidemiological relationships helps us anticipate problems and intervene before catastrophic progression occurs. Early NEC recognition requires understanding that this disease is a master of disguise, often masquerading as sepsis with subtle systemic signs appearing before obvious abdominal findings. Think of early NEC like a house fire that starts in the basement. The smoke detectors upstairs go off first, but you might not immediately see flames. The systemic signs are your smoke detectors: temperature, instability, lethargy, and increased apnea, bradycardia episodes signal something is wrong before the intestinal fire becomes obvious. Temperature instability occurs because inflammatory mediators from the damaged intestine affect the infant's immature temperature control system. Lethargy develops as cytokines impact brain function and energy metabolism becomes compromised. Those apnea and bradycardia episodes that you might initially attribute to prematurity, they're often early warning signs of inflammatory mediators affecting respiratory and cardiovascular systems. The gastrointestinal signs provide more specific clues. Feeding intolerance with gastric residuals exceeding 30% of feeding volume indicates impaired intestinal motility. Serial abdominal measurements become critical. Any increase of 2 centimeters over 12 hours signals significant inflammation and fluid accumulation. Watch the bowel sounds progression. Initially hyperactive as the intestine fights inflammation, then hypoactive, finally absent as ileus develops. The evolution from occult blood to frank bloody stools reflects progressive mucosal breakdown. Here's the crucial point. Recognizing these early signs transforms outcomes. Intervention before pneumatosis appears on X-rays can prevent progression to surgical disease and preserve precious intestinal length. Early recognition literally saves bowel and lives. NEC laboratory and radiographic findings tell a story of progressive intestinal destruction and systemic inflammation. Understanding why these changes occur helps you recognize disease severity and guide management decisions. The laboratory triad reveals the body's response to intestinal catastrophe. Thrombocytopenia occurs because platelets become consumed at sites of intestinal necrosis. Think of platelets rushing to plug thousands of tiny holes in damaged blood vessels, depleting the circulating supply. Metabolic acidosis develops from 2 sources: poor tissue perfusion as the infant becomes shocked, and bacterial metabolism producing acidic byproducts within the necrotic bowel. The refractory hyponatremia happens because inflammatory mediators increase capillary permeability, causing sodium and fluid to leak into the inflamed bowel wall and peritoneal cavity. This third spacing creates the paradox of an edematous, fluid-overloaded infant who is actually intravascularly depleted. Additional laboratory markers reflect systemic toxicity. The white blood cell count can swing either way: leukocytosis from inflammatory response or leukopenia from bone marrow suppression and consumption. Coagulopathy develops as clotting factors become consumed in areas of necrosis, and the liver's synthetic function becomes impaired. Radiographic findings follow a predictable evolution. Early films show nonspecific bowel wall edema and dilated loops, the intestine's initial response to inflammation. The pathognomonic finding is pneumatosis intestinalis, air within the bowel wall itself, created by gas-producing bacteria invading through the compromised intestinal barrier. This finding has 89% specificity for NEC. Portal venous gas represents severe disease, where bacteria and their toxins have migrated through the intestinal wall into the portal circulation. This finding carries 81% mortality because it indicates extensive intestinal compromise and systemic bacterial translocation. Pneumoperitoneum, free air in the abdomen, means perforation has occurred and mandates immediate surgical intervention. Bell's staging system for NEC functions as both a diagnostic tool and management roadmap. Think of it as a GPS for navigating increasingly severe disease. Each stage tells you where you are and what route to take next. Stage 1 represents suspected NEC, with nonspecific findings that could indicate several conditions. Clinical signs include feeding intolerance, mild distension, and stool changes, but radiographs show only normal findings or mild ileus. Management stays conservative: NPO for 48 to 72 hours, antibiotics for 3 days, and serial examinations. You're being cautious without overreacting. Stage 2A confirms NEC diagnosis because pneumatosis intestinalis appears on radiographs, air within the bowel wall itself. Clinically, these infants show moderate illness with absent bowel sounds. Management intensifies significantly. NPO extends to 7 to 10 days, antibiotics continue for the same duration, and serial X-rays every 6 to 8 hours monitor for progression. The radiographic confirmation changes everything. Stage 2B indicates systemic toxicity. These infants develop laboratory abnormalities, mild acidosis, and thrombocytopenia, while radiographs show extensive pneumatosis and portal venous gas. Portal venous gas carries ominous significance, indicating bacteria have breached the intestinal barrier and entered the portal circulation. Management becomes more aggressive: NPO for 14 days, extended antibiotic courses, and consideration for PICC line placement for nutrition. Stage 3 represents life-threatening disease. Stage 3A infants are critically ill with hypotension, respiratory and metabolic acidosis, and DIC. Radiographs show severe ileus and ascites, but no perforation yet. These infants need intensive support: pressors, mechanical ventilation, and surgical consultation for close monitoring. Stage 3B means perforation has occurred. Pneumoperitoneum appears on radiographs. This mandates immediate surgical intervention. The critical teaching point: progression between stages can be rapid. An infant with stage 2A at morning rounds may develop stage 3B by afternoon. Early recognition and appropriate stage-based management directly impact outcomes. Medical management of NEC requires understanding the pathophysiology behind each intervention. Think of NEC management as giving the injured intestine the best possible environment to heal while supporting the infant through a critical illness. The NPO duration follows disease severity because feeding any infant with inflamed bowel risks worsening the condition. Stage 1 gets 48 to 72 hours of bowel rest because the inflammation might be minimal and reversible quickly. Stage 2 requires 10 to 14 days because confirmed NEC with pneumatosis indicates significant bowel wall injury that needs extended healing time. Stage 3 demands 14 or more days because severe disease with systemic toxicity means extensive intestinal damage requiring prolonged recovery. Gastric decompression with a replogal tube serves multiple purposes. The continuous suction prevents gastric contents from reaching the inflamed intestine, reduces pressure on compromised bowel walls, and allows monitoring for bleeding through gastric aspirates. Think of it as taking pressure off an injured area while keeping watch for complications. The antibiotic regimen targets the organisms most likely to cause problems. Ampicillin covers gram-positive bacteria like Enterococci, while gentamicin handles gram-negative organisms like E. coli and Klebsiella that commonly inhabit the intestine. Adding metronidazole or clindamycin provides anaerobic coverage because these organisms thrive in the oxygen-poor environment of necrotic tissue. This triple coverage addresses the polymicrobial nature of intestinal infections. Fluid management becomes complex because these infants lose fluid through multiple mechanisms. Their third-space fluid into inflamed tissues, losing it through increased insensible losses, and often developing capillary leak syndrome. The 150 to 200% maintenance requirement reflects these massive fluid losses. Correcting acidosis addresses both the metabolic consequences of poor perfusion and the acidic byproducts of bacterial metabolism. Early TPN within 48 to 72 hours prevents nutritional depletion during prolonged NPO periods. These critically ill infants have increased metabolic demands while receiving no enteral nutrition. TPN provides essential calories, protein, and micronutrients needed for healing and growth. Hemodynamic support maintains adequate perfusion pressure to promote intestinal healing. Poor perfusion worsens ischemic injury and impairs the body's ability to fight infection and heal damaged tissue. Surgical decision-making in NEC requires balancing the need to remove necrotic bowel against the infant's ability to tolerate surgery. Understanding these indications can save lives and preserve bowel. Absolute indications demand immediate intervention. Pneumoperitoneum means perforation has occurred. Free air equals dead bowel that must be removed. Even without visible free air, a positive paracentesis showing intestinal contents confirms perforation and mandates surgery. Clinical deterioration despite maximal medical therapy indicates ongoing necrosis that medical management can't control. Relative indications suggest surgical consideration but require clinical judgment. The fixed dilated loop sign on serial radiographs indicates necrotic bowel that won't recover. It stays dilated and fixed in position while other loops change. Portal venous gas represents severe disease, where bacteria have breached the intestinal barrier and entered portal circulation, carrying high mortality risk. Abdominal wall erythema suggests transmural necrosis, where inflammation has extended through the entire bowel wall to the overlying skin. Profound thrombocytopenia, unresponsive to platelet transfusion, indicates ongoing consumption at sites of massive necrosis. Surgical approach depends on the infant's condition and size. For babies under 1,000 grams or those who are hemodynamically unstable, bedside peritoneal drainage serves as a temporizing measure. This simple procedure can decompress the abdomen and remove infected material while avoiding the stress of operating room transport and general anesthesia. Stable infants who can tolerate transport undergo formal laparotomy for definitive management. This allows direct visualization of bowel viability, removal of necrotic sections, and creation of appropriate stomas. The key is timing, recognizing when medical management has reached its limits and surgery offers the best chance for bowel salvage and survival. Surgical management of NEC balances a fundamental tension, removing all necrotic tissue while preserving every centimeter of viable intestine. This balance becomes critical because short bowel syndrome represents one of the most devastating long-term complications. The procedure goals follow a systematic approach. First, remove all necrotic bowel, because any remaining dead tissue will continue causing problems. However, surgeons must preserve the ileocecal valve whenever possible. This valve acts like a traffic light, slowing intestinal transit and preventing bacterial backflow from the colon. Its preservation significantly improves long-term outcomes by enhancing absorption and reducing infection risk. Creating a proximal diverting stoma rather than primary anastomosis represents standard practice in acute NEC. Think of this like creating a detour around a construction zone. It allows healing without the stress of immediate reconnection. The inflamed, edematous tissues aren't ready for the mechanical stress of an anastomosis. When bowel viability appears questionable, Surgeons often plan second-look procedures at 24 to 48 hours. This approach prevents unnecessary resection of bowel that might recover with adequate resuscitation and improved perfusion. It's like giving marginal tissue a chance to declare itself viable or non-viable. Post-operative management becomes a marathon, not a sprint. These infants require TPN through central access for 2 to 3 weeks minimum because the surgical stress, ongoing inflammation, and prolonged ileus prevent enteral nutrition. Micronutrient repletion becomes crucial. Zinc for wound healing, copper for immune function, and selenium for antioxidant protection. Monitoring for short bowel syndrome becomes essential. When extensive resection occurs, these infants face prolonged TPN dependence and potential complications, including cholestasis and growth failure. Stoma closures typically occur at 8 to 12 weeks, when inflammation has resolved and the infant has achieved adequate growth. 1/3 of patients develop intestinal strictures at sites of healed neck, often presenting as feeding intolerance weeks to months later, requiring ongoing vigilance throughout the recovery period. I'll continue with our NEC series by covering prevention strategies, which represents one of the most important areas where evidence-based practice can dramatically impact outcomes. NEC prevention represents one of the most powerful tools we have against this devastating disease. Unlike treatment, which aims to limit damage already done, prevention strategies target the modifiable risk factors that tip vulnerable infants toward NEC development. Human milk feeding provides the strongest protection, reducing NEC risk 6 to 10-fold compared to formula. This isn't just about nutrition. It's about active protection. Mother's own milk contains immunoglobulins that coat the intestinal surface, growth factors that promote barrier maturation, and oligosaccharides that selectively feed beneficial bacteria while starving harmful ones. When maternal milk isn't available, pasteurized donor human milk still offers significant protection compared to formula, though mother's own milk remains the gold standard. Standardized feeding advancement protocols prevent the rapid feeding increases that can overwhelm immature intestinal systems. The evidence-based approach of 10 to 20 milliliters per kilogram per day advancement for VLBW infants allows gradual adaptation while monitoring for tolerance. Evaluating residuals before each feed ensures you're not pushing feeds faster than the gut can handle. Probiotics show promise with a relative risk reduction to 0.43 for Bifidobacterium and Lactobacillus strains. However, quality control remains problematic. Pharmaceutical-grade preparations are essential because contaminated products have caused lethal infections in premature infants. Avoiding H2 blockers and proton pump inhibitors maintains the natural gastric acid barrier against bacterial overgrowth. These medications increase NEC risk by 1.78-fold because they eliminate the stomach's natural defense mechanism against harmful bacteria. Antibiotic stewardship proves crucial because prolonged exposure disrupts the developing microbiome. Stop antibiotics within 48 to 72 hours when cultures remain negative. Each additional day of unnecessary antibiotics increases NEC risk by promoting dysbiosis and selecting for harmful organisms. The key insight? Combining these strategies provides synergistic protection. No single intervention eliminates NEC risk, but implementing evidence-based bundles dramatically reduces incidence and saves lives. Spontaneous intestinal perforation represents a distinct clinical entity that must be differentiated from necrotizing enterocolitis, particularly in extremely preterm infants. Understanding this differentiation is crucial because the conditions have different pathophysiology, presentations, and prognoses. Unlike NEC, which involves intestinal ischemia and necrosis, spontaneous intestinal perforation occurs as an isolated perforation without the inflammatory process that characterizes necrotizing enterocolitis. The perforation develops from focal weakness in the intestinal wall rather than from the multifactorial inflammatory cascade seen in NEC. Several specific risk factors predispose infants to spontaneous intestinal perforation. Umbilical artery catheter placement creates mechanical irritation and potential vascular compromise. Early administration of indomethacin or ibuprofen for patent ductus arteriosus closure can reduce mesenteric blood flow, contributing to intestinal wall weakness. Postnatal steroid exposure, particularly in the first few days of life, may impair intestinal barrier function and healing. The presence of significant cardiovascular abnormalities like patent ductus arteriosus or complications such as intraventricular hemorrhage creates hemodynamic instability that can compromise intestinal perfusion. The clinical presentation of spontaneous intestinal perforation differs markedly from NEC in both timing and severity. SIP typically presents much earlier than NEC, usually within the first 1 to 2 weeks of life, while NEC generally develops after feeds have been established for some time. The classic presentation involves acute abdominal distension that may develop rapidly, often accompanied by a distinctive blue discoloration of the abdominal wall. This blue appearance occurs when meconium from the perforation presses against the relatively thin abdominal wall of preterm infants. Critically, infants with spontaneous intestinal perforation demonstrate less systemic toxicity compared to those with NEC. They typically maintain better hemodynamic stability and show less metabolic acidosis. Most importantly, SIP occurs without the preceding feeding intolerance, temperature instability, and systemic illness that characterizes the prodromal phase of necrotizing enterocolitis. The diagnostic approach relies primarily on clinical presentation combined with radiographic evidence of pneumoperitoneum. The presence of free air in the peritoneal cavity confirms intestinal perforation, but distinguishing between SIP and perforated NEC may require surgical exploration and histologic examination. Management follows similar principles to perforated NEC, with immediate bowel rest, gastric decompression, broad-spectrum antibiotics, and surgical intervention. However, the surgical approach may differ, as SIP often involves a single focal perforation that can be repaired primarily, while NEC typically requires more extensive bowel resection. The prognosis for spontaneous intestinal perforation is significantly better than for NEC, with lower mortality rates and reduced long-term morbidity. These infants have less risk of developing short bowel syndrome and show better neurodevelopmental outcomes compared to infants with necrotizing enterocolitis. This prognostic difference underscores the importance of accurate diagnosis and highlights why understanding the distinction between these conditions is essential for both clinical care and family counseling. Understanding abdominal wall defects requires grasping the distinct embryologic origins of gastroschisis and omphalocele, because these different developmental errors explain their contrasting clinical presentations and management approaches. Gastroschisis results from a vascular disruption event further the critical 6 to 10 week period of development. Think of this as a localized catastrophe. The omphalomesenteric artery, which supplies the developing abdominal wall, becomes disrupted, creating a full-thickness defect. This disruption likely occurs when the amniotic membrane ruptures at the base of the umbilical cord, allowing intestinal contents to herniate through the weakened area. The maternal risk factors for gastroschisis reflect this vascular disruption theory. Young maternal age, particularly under 20 years, correlates with this defect for reasons we don't fully understand. More revealing are the teratogen exposures. Aspirin affects platelet function and bleeding risk. Pseudoephedrine causes vasoconstriction, and smoking impairs vascular development. These exposures support the vascular disruption hypothesis. Omphalocele represents a fundamentally different embryologic failure. During weeks 8 through 11, 2 critical processes must occur. The body wall must fuse at the midline, and the intestines must return from their normal physiologic herniation within the umbilical cord back into the abdominal cavity. Omphalocele occurs when either process fails. The risk factors for omphalocele tell a different story. Advanced maternal age correlates with chromosomal abnormalities, which explains why 50 to 60% of omphalocele cases involve genetic syndromes. This association makes omphalocele fundamentally different from gastroschisis. It's often part of a broader developmental syndrome rather than an isolated vascular accident. Understanding these embryologic differences explains why gastroschisis typically occurs as an isolated defect in otherwise normal infants, while omphalocele frequently presents with multiple associated anomalies requiring comprehensive genetic evaluation. These developmental origins guide both prenatal counseling and postnatal management strategies. Understanding gastroschisis versus omphalocele requires recognizing key diagnostic features that immediately distinguish these conditions in the delivery room. Position and covering provide the clearest differentiation. Gastroschisis appears as a para-umbilical defect, almost always right of a normally inserted umbilical cord, with no membrane covering the exposed bowel. Omphalocele presents as a central defect at the umbilical ring, with the umbilical cord inserting directly into a translucent membrane covering the herniated contents. The bowel appearance tells the developmental story. Gastroschisis bowel looks angry, thickened, edematous, and covered with inflammatory peel from chronic amniotic fluid expelled. The intestines appear matted together from this inflammatory process. Omphalocele bowel, protected by its membrane, appears normal and healthy. You may see liver protruding along with bowel in larger defects. Size patterns differ significantly. Gastroschisis defects are typically small, 2 to 4 centimeters, but consequences are significant due to chronic exposure. Omphaloceles vary dramatically, from small defects with only bowel to giant defects containing most abdominal organs. Associated anomalies create the critical management difference. Gastroschisis carries low risk, 10 to 15% associated anomalies, mostly intestinal atresias with chromosomal abnormalities under 5%. Omphalocele tells a different story. 50 to 70% have associated anomalies, and 30 to 40% have chromosomal abnormalities. These features immediately guide your management approach. Gastroschisis requires surgical closure and prolonged feeding recovery. Omphalocele demands comprehensive genetic evaluation and screening for cardiac, renal, and other system anomalies. Understanding these differences helps families grasp the distinct prognoses and treatment paths ahead. Here's what you need to know about managing gastroschisis in those critical first hours. That sterile, warmed bowel bag isn't just a covering, it's life support for exposed bowel. These babies can lose up to 300 milliliters per kilogram per day through evaporation. That's massive for a tiny infant. The bag creates a human environment that prevents this catastrophic fluid loss, while letting you see the bowel condition. Think of it like a greenhouse effect, maintaining warmth and moisture. Positioning matters more than you'd think. Right side down prevents the mesenteric vessels from kinking. It's like keeping a garden hose straight so blood keeps flowing to the bowel. Simple positioning, but it prevents ischemia. Here's a key concept. Fluid requirements aren't your typical maintenance calculations. You'll need 1.5 to 2.5 times normal maintenance with D10W plus electrolytes. Why? Because you're replacing both normal losses and those massive evaporative losses from exposed bowel. Start high and adjust based on urine output and electrolyte levels. The replogal to continuous suction serves two purposes. It prevents aspiration from delayed gastric emptying and reduces abdominal pressure. The inflamed bowel doesn't work normally, so gastric contents just accumulate. For antibiotics, think broad coverage. Ampicillin and gentamicin cover the organisms most likely to invade through that compromised bowel wall. There's no intact barrier anymore, so systemic protection becomes critical. Temperature regulation is crucial because these infants lose heat through multiple pathways simultaneously. The exposed bowel surface, increased metabolic demands, and often poor perfusion. Your lab monitoring schedule reflects how quickly these babies can change. Electrolytes every 4 to 6 hours catch those rapid shifts from ongoing losses, while glucose every 2 to 4 hours prevents hypoglycemia as they burn through their limited energy stores. This immediate management prevents the three things that kill these babies: dehydration, hypothermia, and sepsis. Now that you've stabilized the infant, the surgeon faces a critical decision. Can we achieve immediate closure, or do we need a staged approach? This choice determines the entire management strategy. Primary closure represents the optimal outcome, but it's not always feasible. The criteria provide clear guidance: defect less than 4 centimeters, minimal bowel edema, and adequate abdominal domain. The abdominal domain assessment is particularly important. The abdominal cavity needs sufficient space to accommodate the bowel without creating dangerous intra-abdominal pressure. The monitoring parameters serve as essential safety indicators. Peak inspiratory pressures above 25 centimeters of water indicate excessive diaphragmatic compression, compromising respiratory function. Oxygen saturations below 94% reflect similar ventilatory compromise from a different perspective. Urine output below 1 milliliter per kilogram per hour provides early warning of renal compromise. Excessive abdominal pressure compresses blood vessels, and the kidneys demonstrate the effects of compromised perfusion first. Lower extremity perfusion assessments ensure adequate circulation to the legs. When primary closure creates unacceptable risk, staged reduction provides a safer alternative. The silo functions as a temporary containment system that allows gradual reduction. The custom silo requires suturing to the fascial edges, creating secure attachment. The preformed spring-loaded version offers bedside placement convenience. Daily reductions of 10 to 15% allow controlled, gradual accommodation. This measured approach permits the abdominal domain to slowly expand and accept the returning bowel contents. Rapid reduction risks tissue injury, while excessively slow reduction increases silo-related complications. Most infants achieve final closure between day 4 and 10. The timeline depends on individual tolerance for bowel reduction. Throughout this process, the same monitoring parameters guide clinical decisions. The fundamental principle remains consistent. Safe closure with preservation of organ function takes precedence over speed of repair. Success is measured by achieving secure fascial closure while maintaining adequate respiratory function and organ perfusion. After successful closure, understanding the expected post-surgical course helps guide management decisions. Prolonged ileus represents the most significant challenge, averaging 15 to 20 days. This isn't a complication, it's the expected consequence of the inflammatory peel that develops on exposed bowel. The intestinal muscles can't coordinate properly until this inflammation resolves. Parenteral nutrition becomes essential for 3 to 4 weeks during this recovery period. Extended TPN creates cholestasis risk, requiring prevention strategies like cycling, and newer lipid emulsions that reduce hepatotoxicity. The feeding advancement protocol requires careful monitoring. Start trophic feeds only when gastric residuals consistently remain below 2 milliliters per kilogram, indicating improved gastric emptying. Human milk provides optimal nutrition with growth factors that may facilitate intestinal recovery. Advance slowly at 10 to 20 milliliters per kilogram per day. This measured pace prevents overwhelming the still recovering bowel function. Long-term complications affect significant percentages of these infants. Adhesive bowel obstruction occurs in 15 to 20%, typically presenting months to years later. Growth delays affect 30 to 40%, often persisting through early childhood. Feeding difficulties develop in 20 to 30%, ranging from texture aversions to mechanical problems. These challenges require appropriate family counseling and long-term follow-up planning. The immediate surgical success represents the beginning of a longer recovery process, requiring patience and specialized nutritional management. Omphalocele management differs completely from gastroschisis because of that protective membrane and the high rate of associated anomalies. Your first priority is protecting that sac. The membrane is your friend. Once it ruptures, you've converted a manageable situation into an emergency. Cover it with sterile, moist gauze and handle the infant carefully. Here's what makes omphalocele challenging. 50 to 70% have associated anomalies. You can't just focus on the abdominal wall. You need comprehensive screening. Get an echocardiogram, renal ultrasound, and chromosomal analysis. These other conditions often determine the infant's outcome more than the wall defect itself. Size drives your surgical approach. Small defects under 5 centimeters can usually be closed primarily. Medium defects need staged reduction, but giant omphalocele over 10 centimeters? That's where the paint and weight approach becomes life-saving. With giant defects, the abdominal cavity never developed to house those organs. Forced closure often kills these babies from pulmonary hypoplasia and cardiovascular compromise. Instead, daily application of silver sulfadiazine or povoiodine slowly converts the membrane to skin over 3 to 6 months. The infant grows, the abdomen expands naturally, and you repair the ventral hernia electively when they're 1 to 2 years old. The key insight? Associated anomalies determine survival more than your surgical technique. Pulmonary hypoplasia kills, not the abdominal wall defect. Match your strategy to the infant's physiology. Aggressive early closure isn't always better when the underlying anatomy can't support it. Success comes from recognizing when patience serves the patient better than surgery.